About 8 years ago, there was a brilliant endocrinologist, and she was practicing medicine and was really.
You said she?
She. And when she was practicing, she was very passionate and wanted to help her patients, wanted to do the right thing. As I said, very intelligent, had been trained very well, knew what to do from a textbook perspective, knew the clinical algorithms. But she faced two major barriers that kept good outcomes from occurring. One, when the patient would come in to see her for the office visit, she didn't know what would have been happening and what that patient had been struggling with for the last 90 days. And trying to play 20 questions, say, okay, now 3 Thursday nights ago, you were telling me you were struggling with your glucose, and then you took a pill, and how much, and then you tested again, what was your result, and then did you eat, and when you woke up, if I asked you, this would be a very difficult question. So problem number one. Problem number two, she would then do her best to kind of make up a new treatment plan and write it down on a piece of paper and send the patient out the door, say, please follow this, come back in 90 days. And she felt very guilty knowing that that patient would be making daily, sometimes even hourly, medication decisions, lifestyle decisions, glucose decisions, symptom decisions, and she couldn't be there to support them, as we talked about earlier, in any scalable capacity, even if she was paid to be. That's just impossible. So that's really the genesis of WellDoc. She ended up being our co-founder. Now, how many of you work for a pharmaceutical company? And how many have worked for companies that sell diabetes prescription products? So that's what WellDoc is. We're a manufacturer of a diabetes prescription product. It's the world's first mobile prescription therapy. So this is an FDA-cleared product that's been through multiple randomized controlled trials demonstrating very significant outcomes, 2-point A1C reduction, which is comparable or greater than most diabetes drugs that have been approved and are on the market. It has an NDC code. It has an RX-only requirement by the FDA. So a physician must determine that this is medically necessary for a particular patient. The indication for use is type 2 diabetes, so within the indication. When the physician prescribes a product, it's dispensed legally by a pharmacy like any other prescription product. The insurance claim is adjudicated through the patient's pharmacy benefit. So that's a little bit of if you think about it from your classic life sciences development process, we had to go through the same thing. Multiple years of R&D, multiple years of FDA clearance, multiple years of clinical trials, and now we're just entering into the multiple years of operations and commercialization. The amazing thing is this product has two main features. So one is patient-facing, and it addresses a lot of what we've talked about here. It provides via really an expert system, which is just a fancy way of saying an engine in the background that helps tell a patient what they need to know in the moment that they need it. And to Michael's point, it's not information. What we do is we take data, we skip past information and deliver knowledge and actions to the patient. So in the moment you need, and the other point was not everyone's the same. Every blue star is an N equals 1. So it's tailored, the algorithms are tailored to your medical history, your physician's orders, and your prescription regimen, and then it learns and grows and kind of breathes with you as you go through a progressive, unfortunate, generally, journey of diabetes. So it's giving you what you need to know and what you need to do, and then for the physician, it also loops that back in. When you go see your doctor, it solves that other problem. Remember going back to the problem of making a new treatment plan and says, here's what the patient's been struggling with. As a matter of fact, if you're a primary care doctor and you've got like 2 minutes to even get through any of this, why don't we skip what's been going on and just tell you what you need to do? They're not appropriate for antiplatelet therapy. They should be put on a statin. Their insulin to carb ratio might be off. They're overdue for a foot exam, for an eye exam, these things that you're now getting paid more for if your patients are adhering to. You're the doctor, you make the call. We're just trying to put that information at your fingertips. And what we found in both the clinical setting and in the real world is that it's changing lives. You think about what our founders were up against when they first started and thought, maybe these phones could be helpful for somebody. No one has a data plan. They wouldn't put an application on a phone. They certainly wouldn't use it for healthcare. The FDA wouldn't clear it, wouldn't work, no one would pay for it, right? So, but at a minimum, it's like, well, probably for the tech-savvy kind of person, this might be helpful. And we've almost found the opposite. People that really are already in a position to find a support network, whether it be technology or family members or doctors, are actually almost less in need of this. But fortunately or unfortunately, the majority of the 27 million people with type 2 diabetes in this country are alone out there and don't have a great support network. And so it's now being prescribed by physicians. They're prescribing it from age 22 to 77. Statistically, we're seeing similar clinical impact across age. It's been prescribed almost 50-50 male, women, and the unique thing was that we have seen, and we haven't necessarily correlated this to outcomes, but we're seeing a higher engagement rate in the population 40 to 69, especially 50 to 69, and we were speculating on some of the reasons why. But we've also seen that they're prescribing it across the medication regimen, so they're not just saying this is for someone that's on multiple daily injections, but it's also for people that are not on insulin, and so. It's been a very interesting situation, but I think it's because it's an N=1, right? So it's not for a one-size-fits-all or not for a certain target demographic. How do we fit into patients' lives, doctors' workflow, and payers' existing cash flow models? And so from a patient perspective, you use your existing devices, you use your own phone, your own tablet, your own computer. We're seeing 30% of the people using non-mobile devices, but using their computer sitting on a desk. And and I think that's important to note. It's not our job to tell them which device to use. It's our job to make sure that they can get access to the care they need when and where they need it. I always say if you're being innovative, don't be any more innovative than you have to be, because it gets really hard.